Postoperative acute renal failure. Scenario: a 73-year-old man presents with a Dukes B carcinoma of the descending colon for which he has had a hemicolectomy. Preoperatively his serum creatinine was normal, 103 moles/L, but his urine output has been low since he left the operating theatre recovery suite. This was managed by the surgical team with intravenous fluids and boluses of furosemide, but 24 hours post-operatively you are asked to see him to give a medical opinion because his urine output is 10 ml/hour and his creatinine has risen to 180 moles/L. Introduction. The most common cause of postoperative acute renal failure, ARF, is acute tubular necrosis, ATN. ATN may be the end result of a variety of insults to the kidneys, many of which cause hypoperfusion and initially cause prerenal ARF, Table 8. By definition, prerenal ARF will be corrected immediately when normal perfusion is restored. Management of ARF depends on identification and correction of the cause, treating life-threatening complications, e.g. hyperkalemia and pulmonary edema, and providing supportive treatment, including renal replacement therapy, when required. History of the presenting problem. When confronted with a patient with impaired renal function, it is always important to establish whether this is acute or chronic. In this case, the preoperative creatinine clearly indicates an acute deterioration. In dealing with this patient, consider the following. Consider causes of hypoperfusion, prerenal. These may lead to ATN. Intraoperative hemodynamic details, usually from anesthetic charts, including blood loss, fluid replacement, BP, urinary output, if measured, and time on bypass, if relevant. Postoperative hemodynamic details, including blood loss, fluid replacement, urinary and other fluid outputs, gastrointestinal losses and drains, etc., and BP. Evidence of hypoxia, e.g. low oxygen saturation or dyspnea. Details of all medications, particularly NSAIDs, ACE inhibitors, angiotensin receptor antagonists and nephrotoxic antibiotics. Evidence of sepsis, e.g. fever, hypotension, acute phase response, and wound discharge. Evidence of cardiac dysfunction, e.g. postoperative chest pain may go unnoticed but be an indication of myocardial infarction. Consider causes of postrenal renal failure. Bladder outflow obstruction, particularly in elderly men due to prostatic enlargement. Is the catheter properly positioned and draining freely? Bilateral ureteric obstruction is very uncommon but may occur postoperatively due to retroperitoneal hemorrhage or inadvertent ligation of the ureters, e.g. during hysterectomy. Consider intrarenal renal failure. These would be very unlikely in this case. Acute tubulointerstitial nephritis, usually due to drugs. Disease of small blood vessels, e.g. thrombotic microangiopathy associated with drugs. Examination. As always, the first priority is to make an overall assessment of the patient, i.e. well, ill, very ill or nearly dead. Check in particular for features to support the diagnosis of renal hypoperfusion or postrenal problems. Evidence of likely renal hypoperfusion. Hypotension and postural hypotension, lying and sitting. Low JVP. Presence of sepsis, warm peripheries, bounding pulse, hypotension, and wound infection. Evidence of low cardiac output, cold peripheries, thready pulse, and hypotension. Murmur and/or chest crepitations may suggest low cardiac output/hypoxemia. Blood or fluid loss, e.g. wound hematoma. Evidence of postrenal renal failure. Enlarged bladder due to outflow obstruction. Evidence of fluid overload. In any patient who is acutely unwell or who has renal impairment, it is crucial to establish current volume status. Raised JVP. Gallop rhythm. Basal crackles in the chest suggesting pulmonary edema. Peripheral edema shows that there is an increase in overall body salt and water. Even a trace of ankle edema usually corresponds to at least 3L of expansion. Evidence of intravascular fluid depletion. The following suggest that renal hypoperfusion is likely. Hypotension/postural hypotension. Low JVP. Evidence to support specific renal pathologies. Loin pain can occur with hydronephrosis, rarely with acute renovascular occlusion or embolization, and more commonly with retroperitoneal hematoma. Trash feet as part of cholesterol embolization syndrome, particularly after vascular operations. Drug rash associated with tubulointerstitial nephritis. Enlarged bladder indicating urinary obstruction. Investigations. The diagnosis of the cause of this man's acute deterioration in renal function is likely to be made on the basis of the history and physical examination. However, appropriate investigations will assist in making a diagnosis in some cases and be necessary to assess the severity of metabolic disturbance in progress in all. Assessment of severity and progress. Blood tests, electrolytes, watch for development of hyperkalemia, creatinine, liver/bone function tests, C-reactive protein, FBC, consider postoperative bleeding, and clotting screen, also arterial blood gases, if the patient is very ill or worse. CXR, to look for features of pulmonary edema and/or postoperative pneumonia. Diagnosis of cause of ARF. Urine dipstick for blood and protein. If the cause is prerenal ARF or ADN, one would not expect more than a score of 1+ for both protein and blood. Evidence of greater hematuria or proteinuria in a non-catheter specimen should prompt consideration of a renal inflammatory cause of ARF, although this would be extremely unlikely in this context. Screen for sepsis. Cultures of wound swab, blood, urine, and sputum, if any. Ultrasonography of urinary tract. If a clinical diagnosis of hypovolemia is not clear-cut, look for features of obstruction. Note that measurement of urinary sodium concentration, urinary creatinine or urea concentration, and urine osmolality are of no value in this context. Whether the patient has prerenal ARF or ADN will be determined by his response to resuscitation. Other tests. ECG. Deterioration could have been caused by perioperative myocardial infarction. Management. Treat life-threatening complications, e.g. hyperkalemia and pulmonary edema. Decide if urgent hemodialysis is required and assess whether the patient should be transferred to the intensive care unit. Optimize circulating volume, oxygenation and, hopefully, renal perfusion. The aim is to correct possible renal hypoperfusion while avoiding dangerous fluid overload and pulmonary edema. If renal function improves immediately with fluid infusion, the diagnosis is prerenal ARF. Monitor fluid input and output carefully. A urinary catheter is required. NB. Fluid management of the patient with postoperative ARF associated with hypovolemia. Resuscitate. Give intravenous 0.9% saline or colloid rapidly until the JVP is seen easily and postural hypotension is abolished. Maintain optimal intravascular volume. Give fluid input equal to measured outputs plus 500 plus 1000 ml/day. Examine the patient twice daily for features of volume depletion, low JVP or postural fall in BP, or overload, tachypnoea or basal crackles, and then adjust fluid input appropriately. In the patient with ARF, Always look at the drug chart and stop drugs that have adverse renal hemodynamic effects when the circulation is disturbed. NSAIDs, ACE inhibitors, and angiotensin receptor blockers, or which are nephrotoxic, e.g. aminoglycosides. Repeat measurements of serum electrolytes and creatinine regularly. Particular attention should be paid to the trend as well as the absolute values of abnormalities. If these are getting worse day by day, do not wait until they are extreme before seeking advice from renal services. Once the need for renal replacement therapy becomes clear, usually in the context of oliguria and worsening renal function, there is no point delaying its commencement until there is an emergency indication. Always consider sepsis and set a low threshold for commencing broad-spectrum, non-nephrotoxic, antibiotics. There is very little evidence that prognosis is altered by measures such as loop diuretics and dopamine, which increase urinary flow in people with normal kidneys. Nutritional support is frequently required and should be commenced early in ARF. NB. Management of ARF. Treat life-threatening complications, may require urgent hemodialysis. Restore and maintain renal perfusion. Investigate and correct the cause while continuing supportive management. Further comments. Hemodialysis or hemofiltration. Intermittent hemodialysis is the renal replacement modality used on renal units for most patients with renal failure but without failure of other organs, isolated ARF. Patients who are hemodynamically unstable or who have failure of more than one organ require management in the intensive care unit, where continuous renal replacement therapies such as hemofiltration or hemodiafiltration are the norm. These techniques have the advantage of cardiovascular stability, optimal circulatory volume manipulation and the ability to create space for enhanced nutritional replacement. However, in randomized trials in a variety of settings there is no evidence that one treatment modality is better than the other. Outcome of ARF. Although most patients with ADN have potentially recoverable renal function, the mortality of patients with this condition is high. 40 to 45% of those who require acute renal replacement therapy will die. This reflects the poor outcome of those who have ADN as a component of multi-organ failure. If a patient has failure of 3 or 4 organs, mortality is 80 to 90%. In contrast, mortality is less than 10% in patients with isolated ARF. The renal outcome of those patients who survive is roughly that 60% will recover normal renal function, 30% are left with chronic kidney disease and 10% remain dialysis dependent.